chair about. This is one area in which I'll be, in my first presentation itself, I'll be quote unquote setting the stage or the backdrop, basically the rationale behind why such kind of things might be of use in addictive disorders. That will be followed by the second speaker, Dr. Shubhmohan Singh, who is the technical expert on, particularly on repetitive transcranial magnetic stimulation and also on TDCS. So he'll be talking about the technical parts of it, more or less, and that will be followed by the Dr. Abhishek Ghosh, who is the also the faculty from PGI Chandigarh, all three of us, and he'll be talking about the evidence of efficacy, the challenges, and prospects. So with this, I think I'll start my own presentation rather than talking about it now. It's better that I talk during the speaking. Thank you. Okay, so in this hall, I don't think I need to overemphasize that addiction is common with changing patterns and extent. All those who were there in the presidential address yesterday by Professor P.K. Dalal would vouch for that. He made a very comprehensive presentation on the global and the Indian scenario about various substance use disorders. We also know that effective treatments are available for some, but not for all. For example, there are effective treatments for opioid use disorder, some for alcohol use disorder, for tobacco use, etc., but not for, let's say, cocaine and many other stimulants, etc. Efficacy is modest at the best and probably non-existent at its worst. More importantly, high relapse rate is the rule rather than exception, as we all know, and hence there's a need to explore newer horizons, newer therapies. That's where we come from. One of the basic premises, rightly or wrongly, for this entire session is that the conceptualization of addiction is as a brain disease, otherwise known as a brain disease model of addiction, or BDMA. It's not necessarily fully true, but I'm not going to the controversies related to that, because that's the basic premise from which we have to start here for neuromodulation. As the American Society of Addiction Medicine defines it, addiction is a primary chronic disease of, they don't mention specific substances, but of brain reward, motivation, memory, and related circuitry, neurocircuitry. So it's conceived of as a disorder of neurocircuitry rather than, is it for? Oh, that's very good, wonderful. So rather than of anything else. And dysfunction in these circuits leads to characteristic biological, psychological, social, and even spiritual manifestations. This is from their definition directly, which is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. So some of us would be quite familiar with various versions of this same topic. Essentially, addiction is conceptualized as a progression from an impulse control cycle to a kind of a compulsion cycle. The initial part is characterized by tension, arousal, after taking the drug by an impulsive act, some pleasure, relief, gratification, and then self-reproach or coming down, etc. So that cycle goes on, and gradually the other cycle takes over, where it is no longer so much of an impulsive thing, but more of a compulsive thing. The reward element gets lower, and anti-reward things become more predominant. So it becomes a repetitive behavior, more focused on relief of anxiety, relief of stress, or anticipated relief of stress, and gives an obsessional-like behavior. And that follows this cycle of the first is kind of binge intoxication, and then you have the affective part, and that leads to the preoccupation. So I'm not going very much into this, but essentially it talks about this kind of a progression in a disease. And craving becomes one of the possible target there because it's a marker of the preoccupation anticipation stage with internal and external cues, particularly with perceived substance availability, etc. So craving is a very important thing, and because it's associated with reward. But the point is that reward is not all. Reward processing involves higher cortical functions, and that is where we'll eventually come to, because as you see there RTMS and TDCS, they are primarily focusing on the surface areas, more or less. There are TMS. So higher cortical functions are important in the salience, which means the relevance of a particular stimuli, and that their higher centers get involved. It's not just the typical VTA, nucleus accumbens, dopaminergic route. The valence, which talks about the positive or the negative part of it, is different from salient. Salience is something which just tells you that, okay, there is something in the environment which should grab my attention. That is salience. It may be good, it may be bad. Whether it's felt to be as positive or negative, good or bad, is called the valence. And so there are different circuitries for all these things. And as you will see that cortex is involved in that. And pursuit, which essentially finally becomes a habit, an automated habit. These are all there in reward processing. But, and much more importantly, so these are more or less like bottoms-up kind of process. There are top-down processes where there is major role of prefrontal and cingulate cortex, which are involved in things like choice, decision-making, especially in the context of a conflicting decision, okay, like a delayed discount, etc. Executive function of holding various information online and acting accordingly, eventually talking about cognitive control. And that is where, as we all know, prefrontal cortex plays a huge role. So this is that complex picture. So let's not go much into it, but essentially we are talking about various aspects of the prefrontal cortex. You can see the dorsolateral prefrontal cortex, the ventrolateral prefrontal cortex, ventromedial, the anterior cingulate cortex, and the orbitofrontal cortex. These are important for anticipation, preoccupation, availability, gives the context of it, action inhibition, whether we want to go for a thing or we stop or start, emotion control, and the subjective value of drugs, all these things, okay. The insula provides an internal context by the interoception, that whether I am feeling, integrating the craving state or the withdrawal state and the other physiological states. The hippocampal complex provides the memory and the external context in a reflexive manner. This is the original, this gives you more of the affective component of it, the affective state, the stress, etc. And finally, the action line is through the striatum. As you can see, they are all interconnected. So it's not that you have to directly stimulate the thalamus, because that will be a very tough thing to do. One of the latest systematic reviews done by an important group who have been working for this for now many, many years, more than 25 years, says that they have finally come to 6 circuits. These are latest, so I'm just giving that because there are many different definitions of these brain circuits. These are the 6 circuits. This is an important slide, I would say, copied from that source, and they are all color-coded. So this is the executive network which selects the final response, in which we have the dorsolateral prefrontal cortex, ventrolateral prefrontal cortex, primarily a prefrontal cortical thing. This is the salience network, the orange one, where you have the dorsal anterior cingulate cortex, which says that, okay, this is something which is relevant, okay? So that talks about redirecting attentional resources, and we have the anterior insula, as I said. So they are important. This is the original reward network starting from the nucleus accumbens, but also progresses to prefrontal cortex. The point I'm trying to repeatedly focus on is that the prefrontal cortex is not just a striatal thing in the rats. It goes up to all the way up to orbitofrontal cortex and anterior prefrontal cortex, the pink-colored shadows. That's the reward network. Okay. This is the habit network, which is essentially the striatal part, the caudate and putamen, when it becomes an automated behavior, the dorsal striatum. But even this is connected. They are not isolated networks. They all talk to each other, as we'll see. And this one, precuneus, the posterior cingulate cortex, and some part of the medial, so the midline structures, which is known as the default mode network, or what they have termed as self-directed network, which talks about the internal state, the self-awareness. That's where mindfulness therapy, etc., for example, comes in, mindfulness and those kind of therapies. And finally, the memory network, the hippocampal, parahippocampal system, which provides the context of the learning, retrieving, memory, etc. These are the 6 circuits as of today, probably the best understanding, which are involved in addictive and also most other disorders, right? And I'm not going into the details of that, but you can see that the systematic review have gone through each and every kind of like this drug cue exposure, where all the systems get activated when they're exposed to a drug cue. On the other hand, when there is decision-making related decision-making, then the executive function, the cognitive control function, saying that no, don't go for drugs, it's bad for you, that kind of becomes underactive, that becomes hypoactive, etc. So all these kind of things, the point is that all these circuits are involved, but more importantly, the brain is plastic. Plastic not in that sense, but neuroplastic. So it can change. The large-scale brain networks, they talk to each other, and neuroplasticity is the hallmark. And these patterns of brain activity and the circuitry can be modified. Otherwise, what are we doing here, right? They can be modified by drugs of abuse, as we all know, by repetitive rewarding behaviors like gambling or gaming. That's where the behavioral addiction comes in. So they also change the networks. And by psychotherapies, counseling, psychotherapies, everything. And finally, by neuromodulation. That is where we come in. This is one of the latest, published 23rd December 2019, so less than a month ago, or exactly a month ago, where the ISAM, the International Society of Addiction Medicine Neuroscience Interest Group, it's a comprehensive, wonderful paper worth reading in its full. I have not. But they have provided the roadmap for integrating neuroscience into addiction treatment. And I won't let you go through this very busy slide. I know it's a bad slide, but because it's the original text you have to read. But essentially, they're talking about that similar kind of brain circuits that we have talked about, and they have linked them with fMRI tasks, with cognitive functions, with behavior, and with intervention strategies. This one slide, worth reading, it's an open access journal, Frontiers, is really worth reading. You won't be able to read it, but there are, for example, in cognitive control, there is a role of dorsolateral prefrontal cortex with anodal TDCS or high-frequency rTMS. This is where it goes. But they have also talked about, like mindfulness-based therapies, contingency management, everything. It is related to the neurocircuitry, the plasticity of neurocircuitry, and how we can change it. So I'm coming to the close of my part of the talk. Dr. Shumon will take over, but as you know, the neuromodulation is a form of therapy in which neurophysiological signals are initiated or influenced with the intention of achieving therapeutic effects by altering the function and performance of the nervous system. It's been defined as a bioengineering field also, which encompasses either implantable, like in deep brain stimulation, or non-implantable technologies for the purpose of improving quality of life and functioning of humans, as the official definition given by the International Neuromodulation Society. And it's officially utilized for various chronic pain conditions, some epileptic conditions, some psychiatric disorders like depression and OCD, for example, where it's been some approval is there, movement disorders, etc. In addiction, it's completely off-label, and that's why it's a virgin, rich and interesting area. These are the various kinds of neuromodulation which are available, either with some which produces convulsions, starting from the original or good old ECT, all the non-convulsive or non-invasive, so there the TMS and TDCS comes in, and some invasive conditions which have been tried in some conditions like deep brain stimulation. We'll be talking primarily about RTMS and TDCS. These are the ones which are. So what are the basics of non-invasive neuromodulation? SMS is not that, which you normally know, but SMS is Dr. Shumon Singh. And what is the evidence of efficacy in addictive disorders? Dr. Ghosh. I'll just finish off with something which I found, which is a pre-proof article published in the Biological Psychiatry just now. Yesterday I could see. So it's going to be published probably this month. This is the way things are going at the moment. What they did, they took nicotine withdrawal syndrome, people with nicotine withdrawal. They found by fMRI, their neurocircuitry pattern. They applied transcranial direct current stimulation then and there, and in real time showed how the cognitive circuitry, changes the cognitive circuits implicated. So again, a very complex paper, but they took 3 groups with an anodal DLPFC, these are TDCS, the reverse condition and the sham condition, and showed by fMRI pictures how at that time, directly in real time, the cognitive circuitry is actually changing. So this is something which makes it interesting, and I'll let Dr. Shubhmohan Singh take over the stage from here. Thank you. I think you'll have to.
All right. Okay, good morning, everyone. Thank you, sir. Thanks for the introduction. And I'm Shubhmohan. I'm an additional professor in the Department of Psychiatry, PGI Chandigarh. And I'm going to be talking about one part of this symposium, which is about the role of neuromodulation therapies, progress and prospects. So the basics of neuromodulation I'm going to be talking about. So I have no conflicts of interest, etc. So the 2 main things that I'm going to be emphasizing on is TMS and TDCS as we go along. So when we talk about the basics, it's important to understand where all of this is coming from. I mean, the brain has been known to be a bioelectric organ for the last 200-300 years. And it's been seen, it is known that you can electrically stimulate the nervous tissue, and that includes the central nervous system as well. So it was initially done in frogs and other animals, but later on in humans as well. So when we talk about the neurobiological basis of brain stimulation, I think there are 2 or 3 important things which need to be understood where all of this is coming from. The first thing is that the CNS is sensitive to electric stimulation. The second is that there are different areas of the brain which are devoted or dedicated to different functions and actions. However, it is also a fact that all these areas are interconnected with each other. The brain, as we all know, is a plastic organ, especially in childhood, but also in adulthood. Less so, but it is still there. And when we know that a brain is plastic, by plastic it means that it is changeable in the sense that connections between the different areas of the brain can either be strengthened or can be weakened. And this usually is through environment and through experience and other such things. But it has been seen that in experimental situations, one can use artificial methods to get it. And it is also possible that in humans, one can sort of one can get to desired change by using different methods. And one of these methods is neuromodulation. So what one needs to do basically is plasticity, as we all know, is something which needs time and repetitive stimulation. So once we get repeated stimulation, what we can do is we can get lasting changes which are mediated by the change. And because the brain is interconnected, the different areas are interconnected, it is quite possible that you can stimulate one area and you can have downstream effects at places which are remote to the point of stimulation. So these are the few things which are the most important basic ideas that are involved in neuromodulation. So when we talk about brain stimulation or neuromodulation or whatever you call it, it's been around for a very long time. ECT, we all know, it is a form of brain stimulation. So as I've already mentioned, what you need basically is electricity. So in how many ways can you stimulate the brain using electricity? The easiest and the most commonly used one is ECT. I'll be talking a little bit about that. Then you have TDCS. Directly, you can do something like a vagal nerve stimulation, deep brain stimulation, and the other form is not through direct but through indirect method, which is through electromagnetic induction, which is TMS or transcranial magnetic stimulation, and MST, which is magnetic seizure therapy. So when we talk about indirect, because TMS is something which was important to all of us, is what do we have? We have something which is called electromagnetic induction. If you remember physics, what is there is all magnetism and magnetic and electric fields are very intimately connected. One can lead from one to the other. So what we have over here is that if we remember Faraday's law and Lenz's law, basically these are two laws which show two things. That if you have a rapidly changing magnetic field of sufficient intensity, it can give rise to an electric pulse at a point which is remote to the place where the magnetic pulse was created. So, and as we all know, an electric stimulation which is strong enough can cause a neuron to fire. And what happens is that you can get to an action potential. And if you can stimulate that neuron for long enough in a way that you want to do it, it can theoretically lead to changes in the connections that neuron has with other areas. So what are the requirements for TMS? The requirements for TMS are that you need a large magnitude of a large magnetic field. That magnetic field doesn't have to be static, it has to change. Unless there is change, you cannot have the creation of an electric field. So, and the characteristics of this induced current by this changing magnetic field is that it is efficient, it does not require any direct contact, and it can be precisely delivered. So, over here, if you have a look at this table, what you can see is that you need a fairly strong magnetic field, which is about what you would get in maybe a MRI scan or something like that. So it's not important, it's not enough to basically, for instance, use a fridge magnet as a TMS, because that will simply not create enough energy to stimulate or to get to the action potential. So you need a large amount of energy to give that kind of a field. So this is the kind of schematic illustration of a TMS. Basically what you have is you have a coil through which electricity is being passed, which is sort of leading to a magnetic field, which in turn leads to the creation of an electric current in the cortex, which underlies that coil. So what happens is that, as I've already said, what you need is a pulse. It cannot be a static thing. So basically TMS creates the electric current in the cortex in form of pulses. So these pulses can be used in various ways. The most obvious and the easiest obviously is to have a single pulse. So you get just one pulse, which is basically not very useful. You can, though, stimulate the cortex. It is used for physiological and other basic science experiments. Then you have paired pulses, which is again used mainly for experimental purposes. So basically, as I've already mentioned, because you need repetition to get plasticity change, what you need is repetitive pulses. And these repetitive pulses can basically be given in two forms depending on the frequency at which you are giving them. A hertz is basically the number of pulses per second. So low frequency is usually defined as less than 5 hertz. I've written 1 hertz. It depends. There are different definitions. So basically low frequency and high frequency, which is usually more than 5 hertz, around 10 hertz is usually taken as high frequency. And then you have theta burst, which is basically very high frequency, in which you try to pack in a lot of high frequency stimulations in a lesser amount of time. So as I said, repetitive, RTMS is repetitive transcranial magnetic stimulation. It is repetitive because once is not enough, you need to repeat it. Transcranial because you're not really going into the brain, you are doing it outside through the scalp and the skull. It is magnetic and it is stimulation, which is a bit of a misnomer because it can be inhibitory as well. As I've already said, a single pulse leads to depolarization and an action potential. Repetitive pulses over specific areas, one can sort of, as sir has already mentioned, there are so many areas which are involved in addiction, for instance, in the brain, that so what you basically have to do is you have to look for an area on the cortex which is accessible to a coil, which is accessible to the magnetic coil. So there is modulation of cortical excitability, which finally leads to brain plasticity. So TMS has been around at least since 1985. This is Mr. Barker who first published a paper in Lancet, and this was how it was. And in around 1995, we started to have the first papers on the use of TMS in clinical psychiatric situations. So mostly it was for depression. So I'll just go over a bit of stuff that you need to think of before you start a TMS for a patient. For instance, you need to do a safety screening. The contraindications for TMS, at least as of now, seem to be that a patient who's, say, contraindicated for the use of an MRI, for instance, would be a contraindication for TMS as well, because it's the similar stuff which is going on over there. And other than that, in our experience and worldwide, TMS is fairly safe. There is absolutely, there's not much problem. Some people tend to have transient headaches and stuff like that. But other than that, it's quite safe. So this is the sort of thing that we do. So the other questions that are there is, how do you localize, as I already said, that the effect of TMS or the pulse that you're getting is very localized. I mean, it's only around 4 to 5 centimeters around the coil. So you need to precisely target what you are going to do. So there are two aspects to the target. One is that because you really, all brains are basically different. I mean, within variation, you know, yes, that there is a DLPFC in everyone, but functionally it may just vary a little bit. So you have to be able to target it. The target has to be accessible in the sense it has to be, you have to be able to identify it from prominent landmarks on the skull so that you can target it properly, and it has to be on the surface of the cortex rather than a deeper structure, because your coil is not going to go down that deep. So there are various ways of target localization. One is a 10-20 system of EEG. There are other methods. The most common, for example, targets are the dorsolateral prefrontal cortex, which is usually corresponds to F3 of the 10-20 system. Then there is the supplementary motor area. People also do neuronavigation and other such stuff. So this is the 10-20 system. I'm going a bit in detail about this because the TDCS is also based on similar things. Then you have the stimulus dosing. It is given in various forms. It is basically given in sessions. Each session consists of a lot of trains where you set up a TMS depending upon what you want to do. Most patients would require around 15 to 30 sessions. So one session is usually given once in a day. So your patient would have to sort of come to you maybe around daily for around 3 to 4 weeks. Yeah, so this is the conventional TMS. This is the patent TMS. And there are safety parameters. So mostly, as you can see, low frequency protocols, which is 1 hertz, for instance, are fairly safe even at higher energies. So the whole idea is to choose a coil, create a protocol, decide your variables, number of sessions, frequency of sessions, etc., and assess for adverse effects. As I've already said, side effects are very, very uncommon. However, there are maybe 4 or 5 case reports of seizures that have been reported post-TMS. But that would mostly be for patients who already have some, malformation or something that should have been picked up. So generally, TMS is good for many patients who cannot, for example, access another treatment or are unwilling to take another treatment. So for instance, people who have a medical comorbidity or something may be a good candidate for TMS. When we talk about the direct electrical stimulation, as we already mentioned, ECT is one of the most common examples which come to mind, where you have a large amount of energy over a very short period of time, maybe a quarter, maybe a fraction of a second or a second, and it is non-specific. So basically what you're doing is you're trying to induce a general GTCS, which is like an electric storm inside the brain. TDCS, on the other hand, is giving a small amount of current over a long period of time over a specific target. Interestingly enough, if you kind of sort of look at the entire energy which goes in for a session of TDCS, it is about as much energy as you would give in ECT. In a single, in a single pulse of ECT, you would be giving about the same amount of energy. But because it's a very small amount over a very long period, therefore, it does not lead to a convulsion, for instance. But what it does lead to, I'll let you know. On the other hand, vagal nerve and deep brain are direct procedures where you're basically directly getting inside. So TDCS, it is direct cortical stimulation over a few minutes to half an hour, and it uses bioconducting electrodes. So basically what you're trying to do is you take a point, you take 2 points on the scalp, for instance. One you designate as the anode and one you designate as the cathode, and you try to run a current through the anode to the cathode, and you expect that because the current is passing through the cortex, it is going to lead to some type of neuronal change. Conventionally, it is said that where you have the anode, that point is being stimulated, and where you have the cathode, it is being inhibited. So what you see over here is that the total charge delivered, for instance, is about the same. It is around 1200 to 2400 millicoulomb, and in the ECT, for instance, it could actually be even less than what you would deliver in a TDCS session. So the central dogma, as I've already mentioned, is anodal stimulation and cathodal inhibition. And this is a schematic diagram. What you have basically is a neuron over here, where you have where you have the resting membrane potential, and you can get an action potential. What TDCS is supposed to do is basically shift the resting membrane potential either up or down, depending upon what you want to do. So anodal stimulation is leading to depolarization in the sense that you're going towards the point where you can get an action potential. Cathodal stimulation, on the other hand, is hyperpolarizing it. Therefore, you're going to be requiring more energy to reach to an action potential. So, as expected, there's a lot of paraphernalia which is involved in TDCS. So you have basically these two electrodes, you have sponge pads, this is the device, and basically what you need to do is, because an electrode is put on the scalp, you need good conductance between the skin and the electrode. So basically you need to use something like, for example, a gel, which is a conducting gel. Ideally, there should not be hair or other such stuff. So basically it requires a bit of preparation to start on a TDCS program. The montage or the montage is what is the kind of arrangement of electrodes that you have. Electrodes, again, are of two types. One is a conventional TDCS, where you have one anode and one cathode, so that's called a 1:1. And you can have HD TDCS, which is high definition, where you have one anode or one cathode and many of the other things. So for instance, you could have a 1:4 or even 1:32, which are basically used in sort of research situations. What that does basically is it enables a lot more precise focusing. So for example, in pain protocols or something else, one could use a HD TDCS. The dosing frequency, as we've already mentioned, what is common to most neuromodulations is that you require repetition. It is not enough to do it once. Even DBS, for instance, requires repetition. BNS, all those instruments are implements which are put inside the body for longer periods of time. And there are various protocols. Most published protocols are 2 sessions per day for at least 5 to 7 days. Most of the times, I would say this is a bit of under-treatment. Most people would actually require more time. Skin safety is, again, TDCS is pretty safe. even though most side effects of TDCS are associated with operator error. Mostly it can lead to burns due to faulty sort of installation of the electrodes, use of poor quality gel, for instance, and contact dermatitis, phosphines, etc., etc. The contraindications are about the same. Basically, any metallic, magnetic object inside the brain is basically a contraindication for most types of neuromodulation. So what is, so I've reached the end of my presentation. The point is that again, it is not enough to think of psychiatric disorders as diagnostic entities. They are basically syndromes of signs and symptoms and whatever. When we look at a problem or a patient who has been referred for TMS or TDCS or whatever, I will not look at it like, acha, OCD hai, to you do something. What you are looking at is what kind of behavior or what kind of symptom is the problem symptom and how can you help it. So you try to basically break it down into a problem symptom and you try to see, okay, where is this coming from? Which part of the brain is responsible for this? Is that part of the brain accessible to you or is it amenable to whatever you're trying to do? And then do it. For example, DLPFC is, it is the dorsolateral prefrontal cortex is at the crossroads of a lot of stuff which is going on in the brain. So what is happening is that if you can target the DLPFC, it will lead to downstream changes in a huge lot of places. So that is how this whole business is going along. And so yeah, that's about it. Contraindications are very few and mostly in our experience also patient acceptability is high. And yeah, so I would encourage all of you to sort of read about it and get some experience about it. And Dr. Abhishek now will talk about the evidence base that is there for these treatments in addiction. So thanks a lot. Thank you.
Not showing up there. Oh, yeah, it is. Sure. So I'm going to talk about the evidence base. Now, evidence base. Before I start, I must thank first of all Professor Basu and Professor Submohan Singh for setting this agenda and making the stage ready to talk about something which people usually find a bit boring. So, yeah, I have this disclosure to make that I'm being funded by the ICMR for as a principal investigator for a trial which is on TMS and cannabis use disorders. So, to make it a bit interactive, I would like to have a bit of show of a hand among the audience who are there. How many of you have actually administered RTMS in real life practice? Okay, sir. One. Okay. How many of you feel confident about this mode of treatment? That in psychiatric disorder, okay, once again the same person. That means the others are not very comfortable with the mode of treatment, because we think that psychiatric disorder, of course, is a very complex behavioral disorder. It's a lot of interactions and so, and we are yet to find out a specific brain substrate for a specific psychiatric disorder. So it's almost impossible. We feel it's impossible to target it because we don't know it. How many of you actually feel that RTMS has some promise in addictive disorder? Some promise. There is a light at the end of the tunnel, perhaps. How many of you actually feel it? Once again, one and two. Okay. So that makes my job really an onerous task, I would say, that I am dealing with the audience who are very skeptical. And it's nice actually to be a skeptic. Scientists always should be skeptical. So that's why we talk about the null hypothesis. We first start with there's no evidence exists, and we try to disprove the null hypothesis. So I would say that's That's encouraging. Okay, so this is a very broad and general research question, which if you plan to conduct a trial on RTMS, this is it kind of, is NIBS, I will be primarily talking about NIBS, non-invasive brain stimulation, which consists of primarily TMS and TDCS, because these two modalities of treatment have been primarily tried in patients with addictive disorders. So is NIBS effective in the treatment of addictive disorders? Now it's a very broad question, of course. Now, what do you mean by NIBS? Whether I'm talking about TMS or TDCS is not very clear. There are several types of TMS. Sarah has talked about the theta burst stimulation. There is one deep TMS as well. So what is it? Which disorder are we talking about? Addictive disorder, of course, is a broad umbrella. And as I've mentioned here, addictive disorder. So what I meant, it's substance use disorder plus behavioral addiction, both. So we need to discuss that as well. What effect? Now, effective in terms of what? Reduction of craving, reduction of consumption of the drugs, maintaining a period of abstinence for a long period of time. What is the effect? Now, when you talk about evidence, because it's a very broad, huge area almost, so I took a refuge of the basic tenets of evidence-based medicine proposed by David Shackett and the principles of the PICOT, the PICOT principle. So I would discuss the following slides based on the PICOT's principles. So the P is, of course, the population. So when you talk about population in addictive disorder, so of course, which kind of patients are we talking about? Alcoholic disorder, tobacco, behavioral addiction, the age group which we are talking about is adolescent. Is there an evidence in adolescent? Is there evidence in the extremes of other extreme of age? What sex is? Does sex mediate the effect of this NIBS? Are there any studies related to comorbidities? So population need to understand that. Intervention, now what kind of NIBS process, the area of stimulation, the frequency, the duration, the intensity and the number of sessions, so, and the duration of treatment as well. Then the comparison group, most of the, I will be primarily talking about evidence from the randomized control trial. So most of the studies have used placebo control, placebo in terms of, and most of these have used a sham TMS. Those of you have used TMS or have been using TMS for some time. This instrument, usually the TMS comes with a placebo coil as well. So you can use that sham coil. There are other processes like you can tilt the TMS coil so that it does not produce the desired stimulation. You can use the vertex stimulation, so not targeting the actual area which is to be targeted, or reduce the intensity to a sub-threshold level so that it does not finally reach and stimulate or inhibit the neuron. So these are the various comparisons which are used, and primarily there are trials, RCTs are either parallel design RCTs or crossover trials. Okay, I think I'm getting a bit too technical, but this topic is evidence. When you talk about evidence, you go into the technicalities. Is it all right? Would you like me to summarize the finding, go straight into the results? Because I think that's, is it getting too technical? You can, Frank, is it, right? Okay, fine. So when you talk about the outcome, now the problem is, in all the TMS or NIBS studies, the outcomes are primarily indirect outcome, like people have mostly targeted craving as an outcome. As we all know, that craving does not always lead to drug use behavior, so or change in a particular behavior. So that is a problem with TMS. There are other proxy outcome measures like cognitive functions, spatial executive functions, decision making, attentional bias, etc. Also, there are studies, but in most of the studies, this consumption behavior, maintaining abstinence, it's one of the secondary outcomes. And those of you who have done randomized control trial, you know that secondary outcomes are not adequately powered. The study is not adequately powered to pick up the difference in effects in the secondary outcomes. You cannot reach too much into it. So that's the problem. Another T4 is the time. So after what period of time the outcome is finally measured. Now that is variable. Most of the studies have measured it within 1 to 3 months, but there is one trial which had followed up patients up to 1 year. This is very important because it's frequent complaint, even for people who have been using TMS, that the effect of TMS does not last for a long period of time. So it's an important issue. Okay, so now let us, as I have mentioned, I will primarily talk about TMS and TDCS. So let us talk about TMS, which is the primary population targeted in TMS. So of course, substance use disorder, most commonly studied substance is the tobacco, and least commonly is cannabis. There is only one trial for cannabis, and that is also a feasibility study from the Grants Group in the United States. And hopefully we'll start recruiting patients in PGI very soon in a randomized controlled trial. The behavior, most of the studies are on binge eating disorder, which is primarily the food addiction, the equivalent of food addiction. There is one non-randomized trial which is currently underway in the States for gambling disorder, and there is one proof of concept. There are 2 proof of concept studies for gambling disorder. So the evidence is very preliminary. Most of these patients are using drugs, so they have seen the effect on their craving, and there are only a few trials on abstinent patients, so the outcome there is whether the patient can maintain abstinence for some time with this mode of treatment. Sample size 11 to 115. The trial which we are supposed to start will have 164 patients, so a large number of patients, but a single center trial. Comorbidity, mostly MDD is a comorbidity. There are 2 trials on patients with schizophrenia and smoking. So the numbers are very less to talk about comorbidity. In our trial, we're going to include all the patients, both including and excluding comorbidities. Okay, and both sex, so there is no preferential gender treatment in the treatment. Age group is so extremes of ages were not studied. How much time do I have? Okay. So areas of stimulation or modulation, primarily dorsolateral prefrontal cortex. Primary reason is very accessible, because if you want to, there are 2 problems. One, with the routine coil of RTMS, you cannot reach the deeper structures. Very difficult to reach. You can only cause indirect stimulation. For direct stimulation, and there are deep TMS. H coil is available, but you lose precision in that. So that is the problem. So DLPFC is more accessible, and secondly, DLPFC is the target for depression as well, so people have tried DLPFC. The third reason is, as in those of you who are there during Dr. Basu's deliberation, that DLPFC is one of the primary brain substrate which is responsible for addiction. It has both right and left. DLPFC is primarily responsible for executive function and decision making. So when someone craves for, say, alcohol or tobacco, the left DLPFC might help the person to inhibit the behavior. So there is the tendency of that impulsive behavior to go and have drugs will be controlled by it. Whereas the right DLPFC is primarily responsible for the salience. It's one of the important component of the salience network. So when a person with tobacco use disorder sees maybe a picture of tobacco or somebody smoking, this right DLPFC lights up, so you can stimulate the left. So these are the rational. Rational is mostly neurobiological and logistic, what I mean to say. Superior frontal gyrus. This is an important structure. There's only one trial with smoking with superior frontal gyrus. Okay. So in that case, what I'll do is right, but we cannot talk about evidence unless we know that what we are talking about. But anyway, I will just skip through this slide. Maybe these are the okay. Let's talk about the frequency. So most of the trial have used the stimulation method. So higher frequency of TMS, that is more than 10 hertz, and the modal I'd say that 10 or 20 hertz. The theta burst stimulation is around 50 hertz. There is only one trial, that is a proof of concept trial with the theta burst stimulation. Okay, deep TMS, yes. Type of coil, intensity, it's very important, but most of the time you need to use a supra threshold intensity of motor threshold is 80 to 120%, and modal number of sessions in these trials around 10. Okay, and frequency is daily. Now let's talk TDCS, almost similar profile. Once again, mostly tried in tobacco use disorder, followed by others. Same kind of profile, sample size, okay, comorbidity. So there are not many trials with comorbidity, only occasional studies you'll find with comorbidities. Once again, the area is dorsolateral prefrontal cortex, the primary area which has been tried. There are other like superior occipital area, it's the orbitofrontal cortex area, and frontotemporoparital junction. Anyway, so, and the rationale is once again logistic and neurobiological, as I have mentioned. Number of sessions, TDCS a little less, 1 to 5. TDCS, the evidence is more preliminary and gradually building up. For TMS, the evidence is kind of better. I won't talk about a parallel design and crossover trial because I think I don't have time for that. So the main outcome measure which has been tried is craving. The instrument is visual analog scale is primarily used. There are problems with visual analog scale, but we can take it up in discussions. These are all the other instruments which has been used to measure craving. Okay, this computerized cue-induced craving test, that's a very new instrument which currently we have developed it for opioid use disorder. Probably we'll be testing it soon, and it's a computerized cue-induced craving for opioid disorder. We name this instrument as iCare. Okay, the reductionist substance use is mostly TLFB's timeline follow-back method. These are very technical, I think I'll skip this. Cognitive function, these are the cognitive functions that have been tested, mostly as a secondary outcome measure. There are proxy markers like attention bar, delta wave in EEG, and change in the actual bold signal. So I'll stimulate, Dr. Basu has talked about one of the studies. You actually administer RTMS and see whether there is a change in a bold signal in the fMRI. Okay, it's an impressive. So let's come to the result. If you see that I have not used mean effect size, but rather I have used the confidence interval in the effect size. So you can see that most of the effects, this is the effect size for craving, a reduction of craving or reduction in number of days of drug use. So effect size ranges from small to very large. So the reason for heterogeneity, as I've already explained, is a heterogeneous population. You are using different types of NIBS with various kind of protocol. So it's difficult to reach to a figure, but it has at least some effect, some significant effect, even if small. If you talk about naltrexone, or acampros's effects on craving, it's once again only be small to modest. So it's not much different from other. And this is the main area which, once again, because the evidence mostly comes from studies which have used dorsolateral prefrontal cortex at primary target, so it does not come as a surprise that dorsolateral prefrontal cortex is the target area at this point in time if you want to administer TMS in addictive disorder. High frequency TMS is more effective than low frequency one, and greater number of sessions. And there is a rationale for that, because more the number of sessions, the more the possibility of the neuroplastic changes in the downstream. So if you want to administer TMS, 1 or 2 session TMS or TDCS, whatever, won't be sufficient. TDCS, once again, most of the studies are from tobacco. These are and similar kind of effect size from small, ranging from very small effect size to very large effect sizes for craving and drug use. The area, it's DLPFC, and greater frequency and greater duration of session because of the same rationale, not much different from the RTMS. And it has been shown to improve the cognitive functions. So, and these are all secondary outcomes. Immediate effect is very important rather than the follow-up effect. So, side effects, Dr. So Shubhmohan has already talked about it. I'll skip this. Now, what is the critique? The first of all is the heterogeneity of the trial, which is expected because psychiatric patients with psychiatric disorders, addictive disorders are primarily the heterogeneous population, but we are using heterogeneous treatment protocol as well. So it's very difficult to reach to a particular conclusion from that heterogeneous study. Outcome measure is very important critique because most of the studies have used craving as an outcome measure, which has several limitations. And they have used different concepts of craving, whether it's an episodic urge, craving as concept episodic urge, or the preoccupation. So there is a problem with that. There are serious methodological issues with blinding. Most of the studies have not done blinding assessment. There are problems with washout period and crossover trial. As I've mentioned, sample size most of the time are not adequate, small number of sessions, and generalizability always has been a problem because they've excluded patients with other psychiatric disorders mostly. And these two modalities are primarily being tried. Challenges, we don't know what is the best target area, what we're using, which we are comfortable with. We don't know how to precisely target that area. Neuronavigation is one of them, but we don't know the optimal number of sessions. There's a huge cost which is involved. And there is a problem of treatment retention. As you know, addictive disorder patients are more likely to drop out, and here we're expecting patients to come on a regular basis. We also don't know how to prolong the efficacy beyond, say, 1 or 2 months. Thank you.
Thank you very much, Dr. Abhishek and Dr. Shubhmohan. I think we have run out of time, but we have probably about 2 minutes or something time to take just a couple of questions maybe. And I request the speakers to join me here. Yes, please.
So my question is to you only.
Oh, okay.
Because many times in psychiatry we had been seeing episodic nature of psychiatric substance abuse and dependence, especially in patients who are having bipolarity, sometimes having some other mood disorders also. Do they have different biological underpinning? And if we are able to know those kind of biological underpinning, can we use those strategies in the management of some people who are having continuous dependence?
The short and simple answer would be we don't. We don't know as such or for sure the biological underpinnings of not even multiple disorders but of a single disorder. But yes, we also know that there are multiple circuitry, as has been mentioned aloud, and many of these are overlapping circuitry. So there is a rationale for trying these brain stimulation techniques in multiple conditions as is being done. But the researches, as Dr. Ghosh said, are very few and far between. Because of the time, we could have stimulated you for perhaps more, but I think it's 12:15, and so I'll thank you for being here, and hopefully we are making some progress. Maybe if we continue this symposium after 5 years, if we repeat it, by that time we should be able to come to you with more solid data. In such time, thank you.
So as we are running short of the time, so we will very quickly have the felicitation. Now I will ask the chairperson, Dr. Debashish Basu, to hand over the certificate of the participation to Dr. Abhishek Ghosh. And I will ask Dr. Debashish Basu to hand over the certificate of participation to Dr. Shubhmohan Singh. Now I will ask Dr. Neville Mesquita to please come up on the stage and felicitate to our speakers and the chairperson Debashish Basu. So with this, we will end up this session, and our next session topic is violence and the mental health. And our next session is the school mental health interventions in Indian context, defining the role of psychiatrists. And the chairperson is Dr. Fabian Almeida. And the speakers are Major Anuj Yadav, Surgeon Lieutenant Commander Major Navdeep Banial, and Lieutenant Colonel Arun Yadav.